Hi everyone, and welcome back to part 2 of our preclinical lab preparation for EKG. Let's start the process of EKG analysis that we'll use to figure out rhythms. We make some measurements that tell us how long it takes for the electrical energy to move through parts of the conduction system. That gives us a clue to certain problems. The first measurement we usually make after figuring heart rate is something called the PR interval. That measurement is made from the beginning of the P wave. Now remember, the P wave is this first bump and it's green here. So our PR interval starts at the beginning of the P wave. Now we know that the SA node has fired off somewhere around here, and then this thing that we see as a wave is that wave of depolarization moving through the atria. Actual contraction follows depolarization, so we're not going to have actual contraction of the atria until there. Electrical always precedes mechanical. All right, so we take a look. Remember, we find our P wave and all of that, and then we measure. Now, what we're measuring is the time it takes from the SA node to get to that AV nodal tissue. So the time it takes for that impulse to travel through the atria. Normal PR interval is between 0.12 to 0.20 seconds. Now remember, when we think baby boxes, 0.12 seconds is 3 baby boxes, 0.16 is 4, and 0.20 is 5 baby boxes. So our normal PR interval should be between 3 to 5 baby boxes. What happens if the PR interval is not within normal range? If the PR is shorter than expected, and that's less than 0.12 seconds, then it's most likely that the patient is in a junctional rhythm, and it's typical also that we see that the P wave is inverted, is upside down. And that happens because, remember, if the SA node fails, then our next fail-safe is that junctional tissue at the AV node. So if the PR interval, and the other flip side is that if the PR interval is long, greater than 0.20 seconds, then it might be one of the heart blocks. We have a first degree, 2 second degree, and third degree heart blocks. And first degree heart block basically looks like a sinus rhythm with a lengthened PR interval. We'll talk about those later in class and in ACLS. All right, so we do our PR measurement, beginning of the P wave to the beginning of the QRS. And I'm going to show you how to do this on a strip in just a second. After we do that, the next thing we look at is the QRS complex, or the next thing we measure. And remember, we said that this is my Q wave, my R wave, and my S wave. And this is the big complex we see because energy is moving through. We have a wave of depolarization through the ventricle. And remember, it's big. And so that's why this is big. All right, so our measurement of the QRS starts at the beginning. And so we have our P wave, and remember, this is just a little isoelectric time. The beginning of the QRS is where you see this change. You see the waveform, in this case, our Q wave starts to move down from baseline. So I start my QRS here and go across and find when it goes back, I end it here. Now, the QRS, we move impulses through the ventricle pretty quickly, and so it should be less than 0.12 seconds. That's less than 3 baby boxes. So it can be somewhere between, usually you see it somewhere between 0.06 up to 0.11. Now, if the QRS measures 0.12 or greater, it can be some sort of a heart block in the ventricles. But you need to have a 12-lead EKG to figure out exactly where the problem is. The next thing that we look at, and we don't measure this, we look at the ST segment. Now remember, the ST segment is between, this is ventricles, this is, remember, QRS is ventricular depolarization, T wave is repolarization. So this is just a period of time after depolarization and repolarization where there's no measurable electrical activity, okay? Because of that, the ST segment should be isoelectric. Now remember, we drew a baseline. When there's no waveforms going on, we're going to draw our baseline, and so our baseline goes here, and we see this little interval between the P wave and the QRS comes back to baseline, as it should. And then the interval between the end of the QRS and the beginning of the T wave also should come back to baseline. And then we have our T wave, and you see baseline again. Now, when we look at the ST segment, we don't measure it, we look at it relative to baseline. If it's at baseline, we can say it's at baseline, or we can say it's isoelectric. If our ST segment is below baseline, then we have a depressed ST segment, and that could be a lot of things, but primarily we think about myocardial ischemia or electrolyte disturbances. If the ST segment is elevated, we think MI, we think STEMI, ST elevation MI. Now, there are other things that could cause ST elevation, but we kind of rule of thumb is you think about the worst thing that could be happening and rule that out first. Why would a heart attack or ischemia or electrolyte issues cause problems with the ST segment? Remember that we need energy in the form of glucose and oxygen to fuel the pumps that restore electrolytes back to where they belong. And that gets problematic when there's no fuel. That happens with things like ischemia and MI. And we also know that the electrolytes, sodium, potassium, and calcium primarily, are involved in depolarization, repolarization. So if there's a skew in those electrolyte levels, that can make a mess of things, including the ST segment, and we'll see sometimes with the T wave, and that's the last wave we're concerned with. Okay, so we've got measurement-wise, we found our P wave, we did our PR interval, we're looking at our QRS, we measured our QRS, we looked at the ST segment to see if it's at baseline or if it's elevated or depressed, and now we look at the T wave. Now remember, the T wave represents ventricular repolarization. We're putting things back where they belong. And we remember too that that waveform should be upright and rounded like this. It shouldn't be flat, it shouldn't be upside down or inverted, and it shouldn't be tall and tenty. You maybe remember hyperkalemia as associated with a very tall and tenty T wave and a flat P wave. We're going to measure the QT interval, and that's the time it takes for both ventricular depolarization and repolarization. So because we're measuring both of those things, our measurement starts, at the beginning of the QRS, and so you're going to start right here, and you keep going to the end of the T wave. And so QT interval, and so it's right here. So we've got our two intervals, our PR interval, our QT interval. QT interval starts here at the beginning of the QRS and ends at the end of the T wave. You got to find where it comes back to baseline. Okay, so right here. Normal QT interval is between 0.36 to 0.44 seconds. Now remember that the big boxes are 0.2 seconds, so two big boxes is 0.4, kind of right smack in the middle of that measurement. Now, sometimes the QT interval will be shorter, in a sinus tachycardia, things get pushed together. We worry about the QT interval when it's longer than it should be. And the reason for that is that during our repolarization, pretty much early repolarization, if there was any sort of irritable foci in the ventricle that fired off, it won't change things. But the back part of the T wave, from the slope down here, we've almost got things put back together where they belong, but not quite. And so if an ectopic impulse from the ventricle lands here, it will create a response, but a lot of times it's not normal. It's not what we want. It could cause the patient to go into a lethal dysrhythmia, most particularly torsades de pointe, which is a form of ventricular tachycardia, and like I say, potentially lethal dysrhythmia, so we hate it when that happens. So long QTs are problematic. And there are many things that can cause that we'll be reviewing in class. Now, the actual safe length, because I gave you a range of 0.36 to 0.44 seconds, that actually varies a bit depending on the heart rate, the age of the patient, and the sex of the patient. And so you don't have to know all that. You don't have to figure all that out. Just kind of know that sometimes needs to change. You may see in documentation a big Q, a big T, and a little c, a QTC. And that really means that the QT interval has been corrected for rate. That's what the little c stands for. Now, kind of general rule of thumb is that the QT interval should be less than half of the R to R interval at normal rates. But once again, remember, rate will change that. All right, so we're going to be making some measurement. Now let's start putting things together to analyze. Now, analyzing EKG isn't hard, but it's something that takes some practice. You're pretty quickly going to get to the point where you'll recognize most rhythms by sight. I could guarantee pretty much all of you are going to be able to pick up on asystole, for example. Sometimes, though, you see a really wacky EKG and you work through the analysis and you come up with something, and then you hand the strip to somebody else who interprets it differently. Remember, though, what's the golden rule of EKG? Treat the patient, not the rhythm. Here's an algorithm for EKG analysis that we're going to be using here and in class. First thing you want to do, and steps 1 and 2 are interchangeable, but the first thing we're going to do is check the rhythm. And what do I mean by that? We're looking to see if the rhythm is regular or irregular. Sometimes it's pretty easy to see, and sometimes it's more subtle. And so you need to take a ruler or calipers to measure either the P to P or the QRS to QRS across the strip. And I'll show you that on the next slide. Next thing you're going to do is figure out the rate. Remember, if it's printed on the strip and there's no artifact or any reason to doubt that the number that is there is correct, just go with that. But if you're in doubt or you don't have a number or there's a lot of artifact, get a quick estimate with the 6-second strip method. Now start looking at the individual components. Find the P waves. Remember that the P wave represents atrial depolarization and that they should be upright and rounded. There should be a P wave before every QRS, and the P waves should all look about the same. You're going to measure the PR interval, and remember the PR interval is measured from the beginning of the P wave to the beginning of the QRS. Normal PR interval is between 0.12 to 0.2 seconds, and the PR interval should be consistent throughout. If it changes, then that is a problem. Look at the QRS complex. Remember, that represents ventricular depolarization. The QRS should look the same throughout the strip. It also should not change in shape or morphology, which is the same. Measure the QRS from the beginning of the waveform to the end of the waveform. Remember that it's short. It should be less than 3 baby boxes or 0.12 seconds. We look at the ST segment. We know that that's the time between ventricular depolarization and repolarization when the line should be isoelectric. An ST that's elevated above baseline is ST elevation and not normal. Below baseline is ST depression and also not normal. You'll have to have more assessment and information to figure out what the specific problem is, but we know it's not what we want. Last but not least, you're going to measure the QT interval. That starts at the beginning of the QRS and ends at the end of the T wave, so it includes the entire QRS, ST segment, and T wave. The QT interval should be less than 0.44 seconds, but remember that's just an average. We're concerned about the QT interval when it's longer than it should be. Most of the strips that I used in this packet are from patients in either the tele or ICU where I worked. And a lot of them were going to show 2 leads or views, and that's what you see here. If you only look from one view, if all we look at is one view, you could miss something significant. This lead up at the top here is a lead 2, and it's pretty good at looking at atrial dysrhythmia. This lead down here is a V lead, and it's better at looking at things going on in the ventricles. So if you're worried about a patient that could be having a heart attack, you don't want to just look at a lead that's really only going to show you what's going on in the atria, because heart attacks are ventricular. Now, these look different, but they're both pictures of the same thing. It's just that they're essentially from different angles. If you walk around a person, they're going to look different depending on the angle that you see them. For our purposes, pick the view that's easiest for you to find the parts and pieces. So let's apply the algorithm you just learned to figure out what's going on with the strip. I know it's labeled sinus rhythm, so there's no surprises here, but why? What made it sinus rhythm? Because I won't put labels on the things I'm going to test you. You're going to have to figure it out. Remember, first order of business is to determine whether the rhythm is regular or irregular. Now remember I said there's a couple ways to do that. I mean, you can look at it and you can see that it looks pretty regular, but we've got a couple strips coming up where there's some subtle changes that, it might be helpful to be able to march things out. Now, one way is to use calipers. You don't have to go out and buy calipers, by the way. They're kind of nasty because they're very sharp, and I can't tell you how many times I stabbed myself with those suckers. But if you happen to have some, or a set, you just go ahead and you mark, you'll see, you mark and you set it between two QRSs, and then you continue to march it through the strip to make sure that everything is at the same interval. The other way, and this is what I'm going to have you do when I have you in class, is to get yourself a piece of paper and something bigger than this. This is just a scrap, but just make a mark at this QRS and this QRS, and then move the paper down the strip as a ruler to make sure that the QRSs are actually equidistant apart from each other. On this one, yes, the QRSs are pretty much the same width, so this is a regular rhythm. Now we're going to calculate the rate. Remember, we want to find 6 seconds worth of strip, and so you see the marks at the bottom. What do I got here? Okay, I got a mark here, here, and here. So from here to here is 6 seconds, and I'm going to count QRSs. 1, 2, 3, 4, 5, 6, 7, 8, 9 QRSs. Remember, I want this by minute, and I only have 6 seconds worth, so I multiply 9 by 10, and I get an estimate of 90 for the heart rate. Now, remember, this is only an estimate, but it's good enough. Remember that 60 to 100 is considered a normal rate range. Less than 60 is considered a bradycardia, and 100 or greater is considered a tachycardia. Now, you'll notice I didn't put sinus in front of that because we haven't determined that yet. Next thing you're going to do is look for the P waves. Now, that's the small wave before the QRS, and so we have a P wave here, here, and here. This is essentially the P wave, the QRS, only you'll notice there's no Q. This is just an RS, and the T wave, okay? So P wave, and I want to find the P waves, and I just want to look through and make sure they all look about the same, which they do, okay? And there is a P wave in front of every QRS. Now I'm going to measure the PR interval. By the way, the P wave on this V lead is this bump right here, okay? So it doesn't show up really well there. And this is kind of a weird looking V lead. All right, so PR interval, remember I'm going to measure from the beginning of the P wave to the beginning of the QRS. And I thought I had one that would kind of line up for you. Okay, this one right here. Now you can take your paper that I showed you for your measuring the R to R. You can take your paper and set it next to a good looking P to QRS, and just put a mark on the paper at the beginning of the P wave and another mark on the paper at the beginning of the QRS, and then you can kind of move it down to where you see the boxes a little better. But because this one starts on a dark line, it's a little bit short of it and ends a little short of a dark line, you can see that I'm covering about 4.5 baby boxes. So that if it's 4.5 baby boxes, that would give me a PR interval of 0.18 seconds. Remember, each baby box represents 0.04 seconds. So 0.04 times 4.5, because I'm saying it's 4.5 baby boxes, equals 0.18. If you look at it and you say it's 5 baby boxes, that's fine. You'd have a PR interval of 0.20. Remember that a normal PR interval is between 0.12 and 0.2 seconds. So far, so good. And actually, because I already know the rhythm is regular, the rate is in the 90s, and I see a P wave in front of every QRS with a normal PR interval, I already know that this is a sinus rhythm. I know this came from the sinus note. But I'm not done yet, because I need to look for other problems. Next, I look at the QRS complex, and that's our QRS complex in lead 2 and the QRS complex in the V lead. And by the way, this is not a normal looking V lead. A normal looking V lead would have an upright P wave, a negative QRS, and an upright T wave, okay? So even though ultimately we're going to say this is a sinus rhythm, there are still some other issues here. Okay, QRS is ventricular depolarization, and I look to make sure that they all look about the same, which they do, and I'm going to measure my QRS. And remember, you're going to start at the beginning of the QRS, which is right here, and you go to the end of the QRS, and on this one, I can see that I actually covered 2 baby boxes, and so my QRS measures 0.08, and that's fine. That's within a normal range. The ratio refers to the ratio of P waves to QRS, and the ratio on this is 1 to 1. Next, I look at the ST segment. Now, remember, the ST segment isn't a waveform. It's this little point in time that's between the QRS and the T wave, and it's between depolarization and repolarization, and there shouldn't be anything that we can see electrically, so it should be isoelectric or at baseline. Now, notice that if you draw a line to establish baseline, that you see that in the upper lead, the ST segment is depressed by about 1 millimeter in depth, 1 baby box. And so let me draw that across so you can see. So like here, 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 you can see I've got some ST segment depression. But I also see a funny little dip here, and the other thing I notice is that my ST segment in the V lead looks just fine. So can I say that there's a problem? Not really. I mean, it does look like I have some ST segment, but what do I do with that information? Assess the patient, review the labs, look to make sure that the lead is attached correctly. It could be artifact, try to figure out what's going on. So I would have to say that I'm seeing a little bit of ST segment depression. Next thing I'm going to do is look at T waves. Now remember, T waves should be upright and rounded, and these are a little on the tenty, kind of pointier side in the upper lead, and they're inverted in the lower lead, which they should not be. They should be upright and rounded in the lower lead. So there is a problem with repolarization. I don't know what yet. We would need a 12-lead EKG to get more information on that. I am going to, after I've observed my T waves, I am going to measure. Remember, the QT interval encompasses the QRS, the ST segment, and the T wave. And so I start at the beginning of the QRS, and I end at the end of the T wave. And you'll notice on this that that encompasses 2 big boxes. So I have a QT interval of 0.4 seconds, which is within normal limits. So we have a sinus rhythm, but as we noted, there's a few issues that need to be investigated. Now, setting, because I know that's on your handout, sinus rhythm is considered normal, but as you can see, as I said, some things we need to look at, some potential problems. Remember also that just because you see this lovely electrical pattern on the monitor, your patient isn't necessarily stable or even alive. A patient can have this rhythm on the monitor and be dead. No pulse, no response. So no intervention, though, is needed as long as the patient is alive and hemodynamically stable. All right, next strip. Let's go ahead and check the rhythm. Is it regular or irregular? And I'm gonna ask you guys to take more of a look at this as you're going along and figure it out. Even pause the recording and take your piece of paper and mark it out, and then march out between the QRSs. Just take a second to do that and then come back. If you marched it out, QRS to QRS all the way through, it is regular. Next thing we want to do is figure out the rate. And so you're going to find your 6-second section and count the QRS complexes. And so we start here to here is 3 seconds, to here is 6 seconds. So I've got all of this for a 6-second strip, and you've counted the complexes, and you should have counted 5 in that 6 seconds. We multiply 5 times 10, and we get an approximate rate of 50. Remember, we can't say the rate is 50. We say it's approximately 50. Next thing we do is find the P wave. And so here's my lead 2 again. And this, by the way, is also not the way a lead 2 should look. A lead 2 should have an upright P wave. All of the QRS should be upright, and the T wave should be upright also. Okay, so a little bit of issues with this. Many of these patients were folks sitting on tele or ICU that had had heart attacks or cardiac events, and that's why we see some funky things. All right, so I've identified my P waves, and I do have a P wave in front of every QRS, and they look about the same. Okay. Okay, remember that represents atrial depolarization. Next thing I'm going to do is measure the PR interval. So you're going to measure from the beginning of the P wave to the beginning of the QRS, and I want you to hit pause and make that measurement and then come back. All right, so if you're back, you should have had a PR interval of around 0.16 seconds or 4 baby boxes, and we know that's a normal range. Next thing we're going to do is look at the QRS waveforms. Now, I did identify to you that they really shouldn't look this way, but they do. V-lead should be like this. The QRS should be upside down like that. And so then we do a measurement of the QRS, and it's from the beginning of the QRS, this point right here. Do you see how it just rises from that baseline to the end? And that's this point right here. This point right here is something called the J point. It's the end of the QRS and the beginning of my ST segment. And so if I measure across, I got 2 baby boxes. Hopefully you did too. Now that's a normal range. Ratio is 1 to 1. I have 1 P wave for every QRS. And where we see a different ratio is, I mean, there's other dysrhythmias that show us a different ratio, things like blocks. After that, I'm looking at the ST segment. Remember, it's not a waveform. It's this point between the QRS and the T wave where things should be, there shouldn't be anything measurable electrically, and so it should be at baseline, which it is up in the lead 2, okay? Now I'm going to find the T waves, and as you're looking at them, you may notice that they're not, as I pointed out before, they're not upright and rounded, they're inverted. And so that's not a normal configuration, but you know, they're T waves. You also notice in the V lead, we really can't even discern T waves at all. But go back up to lead 2, put me on pause, and measure the QT interval, and then come back. All right, I got a QT interval of, it's two big boxes plus a baby box, so 0.44 seconds, okay? Now, if you look at the last complex here, it's a little bit easier to see because the QRS starts on a line, and then we come back up just a little bit over, and that's where I got my 0.44. Okay, so 0.44 seconds. Now, setting. What kinds of things can cause sinus bradycardia? Now, a well-conditioned heart has enough contractility to move adequate cardiac output without having a very high rate. So the resting heart rate may be in the 50s or even something like 48 or so, and that's okay. But how do I determine okay? Assess. What am I assessing? I want to see if the patient's hemodynamically stable. So what am I going to do? I'm going to assess blood pressure, skin color, temperature, capillary refill, pulse amplitude, level of consciousness. Is the patient having any chest discomfort or dyspnea, shortness of breath? Those are the kinds of things I'm going to assess. Now, when you guys listen to the American Heart Association ACLS videos, you notice that American Heart Association defines unstable patient as blood pressure less than 90 systolic, chest pain, the patient's having chest pain, the patient has a change in their level of consciousness, or they have signs and symptoms of heart failure or shock. Now, other things that can cause bradycardia include sleep, in certain stages of sleep. So if you're on night shift, you may see this. Heart rate can drop pretty low, but as long as the patient's hemodynamically stable, it's a normal finding. Vagal stimulation can cause this, and so that can be stimulation, of course, you know, things like coughing and pooping, but also vomiting, severe pain, suctioning can cause vagal stimulation that can drop the heart rate. Hypothyroidism, increased intracranial pressure, conduction system problems, heart attack, and medications can slow the heart rate down. So an example of medications that are negative chronotropes, which means it slows the heart rate down, are calcium channel blockers, beta blockers, and DIG. Now, the intervention, you know, whether you need to intervene or not is based on whether the patient's symptomatic or asymptomatic. It's based on your patient assessment. Because like I said, you could have a patient with a heart rate of 44, but if they're warm, dry, mentating, the blood pressure is greater than 90 systolic, they're not having any chest pain, shortness of breath, their lungs are clear, well, we don't have a problem, but you're going to continue to assess and monitor, and if this is a change, you're going to certainly notify the healthcare provider. If they are symptomatic, we're going to follow ACLS algorithm for symptomatic bradycardia. So what does the ACLS algorithm say? Get a 12-lead EKG if we can. If you need to do something fast, then we go to the next step, which is administer atropine. Atropine is an IV medication that increases conduction through the AV nodes, so it should increase the heart rate, and if we increase the heart rate, we get a better cardiac output, and hopefully we fix the symptoms. The dosage on atropine is 0.5 milligrams. You can give it every 3 to 5 minutes, up to 3 milligrams total. If atropine doesn't work, the patient may require either transcutaneous pacing, which is temporarily pacing the heart through the through the chest wall, or we can start an infusion of either dopamine or norepinephrine to improve perfusion. And by the way, that was the ACLS algorithm for bradycardia. Yay! If you can learn that, you got that algorithm down pat. We're also going to try to figure out what's causing the problem and fix it. Okay, next strip. Once again, I know it says sinus tachycardia, but how do you know? Let's go to the algorithm. I want you to try to figure out on this on your own as much as possible. So hit pause as we move through each item so you have time to measure and think about questions. First off, we're going to determine whether the rhythm is regular or irregular, and you're going to figure the rate. I want you to hit pause and figure both of those things and then come on back. All right, you're back. Rhythm is regular, okay? The rate, you should have counted 11 complexes in 6 seconds, so you should have a rate of approximately 110. So we do have tachycardia. Next, you're going to find the P waves. Now, one thing you may notice when you're looking at this strip is, especially the front part of this strip, there's a bunch of gunk. There's a bunch of artifact. Remember, we're recording from electrodes that are stuck on a moving, breathing, scratching, itching, coughing person. And some of the weird bumpiness that you're seeing is most likely because of that. It might be that we need to make sure that the electrodes are sticking really well. I'm mentioning that now because once you have to find the P waves, you always need to look to be sure that they look the same, and the first couple complexes look kind of wonky, but that's just artifact. Now, we found P waves, okay, so we found our P waves, and we know that these weird-looking P waves are artifact, the rest of them look about the same, and so that's a good thing. Measure the PR interval, hit pause, and do that now. All right, so remember you measured the PR interval from the beginning of the P wave to the beginning of the QRS. So for example, in this one, I would have measured from here to here. And you'll notice that it looks like it covers about 3.5 baby boxes. If you got somewhere between 3 to 4 baby boxes, you're fine. So if you got something between 0.12 to 0.16 seconds, that's fine. We have a normal PR interval. Now we find our QRS complexes, and we do look to make sure they look about the same and they're marching all the way out. Hit pause and measure the QRS complexes. Okay, so you should have measured from here to here, and that covers 2 baby boxes, and so that measures out at 0.08 seconds. We do have 1 P wave for every QRS, so our ratio is 1 to 1. And next we're going to find the ST segment. So remember, the ST segment is this little bit of time. Now I got some bumpy artifact here, so I'm going to ignore this. But it's this little bit of time after the QRS, okay, to the T wave. Well, where'd my T wave go there? Yeah, that's kind of ugly, huh? How about this one? QRS to T wave. QRS to T wave. Well, it does appear that there's a little bit of ST segment depression for a little bit all the way through, but not on all. Some of these like that look fine. Now, if you really have ST segment depression, it's not going to be scattered around here and there. It's going to be out through the whole thing. And when I look at the V-lead, I don't see any ST segment depression at all. T-wave is hard to see on both leads. So what I do is I find the complex that looks the best. And so maybe this one right here looks about the best, and so I can see my QRS, a little tiny dip here. T wave is upright and rounded, so I can say the T wave is upright and rounded. I'm going to measure my QT interval on this one, beginning of the QRS to the end of the T wave. And I'm just one baby box short of two big boxes, so I'm measuring that at 0.36 seconds, okay, which is within a normal range. Let's talk about setting for sinus tachycardia. If you're out running around and exercising, doing things like that, then tachycardia is compensatory because your heart is trying to increase cardiac output so you got more oxygenated blood flow to your muscles. And that's expected and normal. But if your hospitalized patient who's pretty much just been laying in bed is tachycardic, then there's a problem. You need to assess your patient, figure out what that problem is, and fix it. Now remember, our bodies have some amazing compensatory mechanisms, but we can reach to the point where we're at the end of the rope and then they will crash. So you need to pick up on this before they crash. Now, if you fix the problem, that should fix the tachycardia. So we don't really try to give meds to fix tachycardia per se, we fix the problem. What kinds of problems could occur? Well, tachycardia is a compensatory mechanism for things like hypovolemia or hypervolemia. Look to see, is your patient bleeding? Are they dehydrated? Or is there heart failure, too much volume? Other causes include things like pain, sympathetic nervous system stimulation, anemia as a compensatory mechanism, shock, fever raises the metabolic rate and heart rate, anxiety, and then meds. Some meds that we give, like atropine, I talked about that before for bradycardia. We're not going to give atropine to somebody that's tachycardic. Aminophylline, which we don't use all that much anymore, that can raise heart rate, and there's some other things. Then there are stimulants like caffeine and nicotine, or illicit drugs like cocaine and amphetamines. Those aren't things we're given to patients, but sometimes things happen. And there can be problems with the patient's sympathetic nervous system that can cause tachycardia. So once again, what's our intervention? Figure out and fix the underlying problem, and tachycardia fixes itself. All right, we're going to venture into something a little bit different. Premature atrial contractions, or PACs, are not a rhythm. PACs are what's called an ectopy, meaning that there's something happening on top of an underlying rhythm. Now, PACs are a real common ectopy. I would venture to say that all of you have had PACs at one time or another, and you may have been aware of it because it may have felt like you had a little bump in your beat or whatever. Most of the time you're not. Let's take a look at the strip. Now, first off, remember, we determine whether the rhythm is regular or irregular. You see that it's regular with two exceptions. Okay, I'm pretty good here, but then I have an early beat right here, and then I'm nice and regular here to here to here. There's the second early beat, and then I go back to being nice and regular. Okay, now what we're going to do to figure this out is ignore the early beats. Ignore those, and we're going to figure out what the underlying rhythm is. So if we ignore those, we can say that the underlying rhythm is regular, okay? You're going to calculate the rate exactly the same as before. Find 6 seconds. Now, this strip was cut badly, and what I did is I went ahead and measured from here to here, right below the V, is 6 seconds. And so we're going to count 1, 2, 3, 4, 5, 6, 7, 8. I have 8 complexes in that 6 seconds, so I know that gives me an approximate heart rate of 80. I'm still ignoring the early beats. Find P waves. And you'll notice that I have a P wave, a P wave, I'm ignoring this, a P wave, a P wave, a P wave, a P wave. Every normal beat has a P wave in front of it. Okay, so my underlying rhythm is regular, my rate is 80s, and I have a P wave. I can measure the PR interval on these normal beats, okay, and it looks like my PR interval is, you could have gotten somewhere between 0.16 and 0.20, either 4 to 5, maybe baby boxes. So I have a normal PR interval. QRS complexes all look about the same. You'll notice even on the early beat, QRS complexes look about the same. So let's go ahead and measure the QRS complex. You can hit pause. And once you've come back, you probably had 2 baby boxes or 0.08 seconds, which is normal. Remember ratio, we're going to ignore the early beats. Ratio is still 1 to 1, 1 P wave for every QRS. Let's find the ST segment. Notice that the ST segment is pretty isoelectric except for here, but this is the early beat, so I'm going to come back to this. I'm going to ignore this for now. ST segment here, here. So ST segment looks fairly isoelectric except for the early beats. So for the underlying rhythm, I can say that ST segment looks okay. Locate the P wave or the T waves, and we notice that they're upright and rounded. This one, P wave, QRS, that looks a little different. But remember, this is my early beat, so I'm going to come back to that. T wave, T wave, T wave. So upright and rounded. Now hit pause and measure the QT interval. All right, if you're back, you should have gotten the QT interval at 2 big boxes, and so my QT measures 0.4 seconds, which is within normal limits. So with that information, I can say that the underlying rhythm is a sinus rhythm. But let's go back to the early beats. What happened there? I have a sinus rhythm, but what happened? Now, if you look at this early beat, remember, we're going to start with the beat before, because we identified a P wave, a QRS, and then there should have been a T wave here. If this is early, there should have been a P wave here, QRS, T wave, okay? So that one beat, I can't see the T wave from the previous beat, and I can't see the P wave from the early beat. What do you think happened? Now, if you guess that they both landed on the strip at the same time, you're right. What you see here in front of this early beat is a combination of a P wave and a T wave. Okay, so we actually did. This early beat does have a P wave, has a QRS and a T wave. Okay, so the thing with PACs, they're caused by an irritable area, irritable foci in the atria that wind up firing off before the SA node could. And because of that, you see this early beat, but you notice that we still, we still had this P wave, the QRS looks the same and all of that. So it follows the same pathway. It just jumped in a little bit earlier. Okay. All right. Oh, okay. The other thing I wanted to mention is the ST segment depression here. Now, you don't usually see this, and we only see the ST segment depression in the 2 early beats. This is actually not something that's real common with PACs. Usually PACs, we still keep a isoelectric baseline on our ST segment. But remember, one of the causes, we think about causes of ST segment depression, we think typically about ischemia or electrolyte. Can't be an electrolyte issue, because if it were, the ST segment depression would continue throughout. Could it be ischemia? Yeah. These are early beats, and because these are early beats, we didn't get a lot of time to fill the ventricle or perfuse the myocardium, and that's why we have ST segment depression. Ischemia just in these early beats. Like I say, this is kind of an interesting finding. That's why I kept the strip, because I thought it was interesting. All right, so we've established we have an underlying sinus rhythm. Setting for PACs, like I say, common, occurs in both healthy and diseased heart. We can see with coronary artery disease, valvular disorders, DIG toxicity. By the way, DIG toxicity can cause any dysrhythmia known to man. Anything that increases some, sympathetic nervous system stimulation can cause, PACs, COPD, heart failure, MI. A list of things. And sometimes they happen, we don't really know why. So intervention is generally not needed. Basically, if it appears that it's influencing cardiac output, then our focus is on figuring out what's causing the problem and fixing that. Sometimes we will see that patients that go into atrial fibrillation had some more frequent PACs prior to going into AFib. So usually that's something we figure out afterwards, because it doesn't always happen. All right, this is our last slide for preclinical lab, and it's atrial fibrillation. Now, with atrial fibrillation, the SA node is no longer in command of the heart. Fibrillation, that word fibrillation is quivering, and it's caused by rapid discharges from many irritable foci in the atria that are rapidly firing all at once. That doesn't work so well, and the resulting rhythm is erratic and uncoordinated. If you could look at the atria, you would see that they're just quivering. Now, we can't actually count the number of discharges that are stimulating the atria, but it could be as many as 300 or 400 a minute. Atrial fibrillation is actually easy to figure out. There's 2 hallmarks. The AFib is irregular, and there's no discernible P waves. So let's take a look at it step by step. Is the rhythm regular? You can hit pause, but you really don't have to, because you can see, there's a little spot here where you got two beats that look like they're apart from each other. But remember, a regular rhythm is regular throughout. So this is irregular, okay? And there isn't a pattern to it. So the next thing we do is we're going to calculate rate. And, same thing, we're going to calculate by QRS complexes. And from here to here is 6 seconds. So I count 1, 2, 3, 4, 5, 6. My rate is approximately 60. The next thing is to look for P waves, and you'll notice that you do have some bumpity lumpity stuff along here, and you could look at that and go, oh, hey, there's a P wave. But remember, P waves are consistent and they march out all the way through. You're not seeing P waves here or here. What you're seeing is the fibrillatory baseline, okay? So already, what do I have? No P waves, and it's irregular. I already know this is AFib, but we're not done yet. You still need to look at like the QRS complex. Now, one of the things you got to remember here when you're looking at the QRS and you're looking for T waves and things like that is that the fibrillation doesn't stop. We're still recording fibrillatory waveforms, and so that'll skew the way sometimes QRSs look, and it'll skew the way that the T wave looks, okay? So what are we going to do? You can measure the QRS, find the one that looks the least impacted, and I'm probably going to pick this one right here, or maybe this one. And it looks like it's 3 baby boxes across, maybe a little short, but I'm guessing it, or I'm looking at it at about 3 baby boxes, or 0.12 seconds. That's a little on the long side, because remember the QRS should be less than 0.12. And remember, the QRS measures the time it takes for conduction through the ventricle. Something may be going on to slow things down a little bit, but we're going to need a 12-lead EKG to figure it out more specifically. Now, on the ratio, since there's no discernible P waves, we do not have a ratio, okay? And as I said, the T waves are a little harder to see. So find the T wave that looks the best. I can see the T wave here. I might even see a little ST segment elevation here. It's really hard to tell, but I can see my T wave here, okay? So I can look at that, and I can do a QT interval with it. So I can measure from here to here. Remember, QT encompasses the QRS, ST segment, and all the way to the end of the T wave. And so I'm looking at that, and I come up with 0.36 seconds. It's almost, but not quite 2 big boxes, okay? So the QT interval looks okay. Now, just AFib in general, this is actually a relatively common dysrhythmia. It can be acute or chronic. We'll be talking more about this in class. We'll talk about the difference between the two and, treatment management options. Always assess your patient to determine whether they're hemodynamically stable. If not, we have to fix that. Usually we start out, if they're hemodynamically unstable, by looking at the rate. And we'll talk about this. We've already determined the rate for this is 60, and that's pretty good for AFib. The reason rate is such an issue is that when atria just quiver, we don't get atrial contraction. Now, normally, the atria actually contract at the end of diastole. The first part of diastole, really all the way through, is, the first part of diastole, the AV valves open, and blood from the atria rushes into the ventricles due to a pressure gradient, because those ventricles are almost empty, so pressure in the ventricle is lower than that full atria. Atrial contraction occurs at the end of diastole. We call it atrial kick, and it adds about another 20% or so to ventricular volume. With AFib, there's no atrial contraction, no atrial kick, so we don't get as much volume in the ventricle as we would otherwise. That's why we need diastolic filling time. That's why we have to look at rate. If the patient gets really tachycardic, we lose diastolic filling time, and cardiac output goes down. Our compensatory measure for a decrease in cardiac output is to increase the rate even further. And so this really makes it hard to manage. It's like a snowball rolling down the hill. So, we want to make sure that we get adequate filling. Now, how do we do that? If AFib is fast, first we want to make sure there's not an underlying problem that's causing the rate to go up. An example would be dehydration or pain. We would fix that. We may need to give medication to slow the rate, and that can include things like beta blockers or calcium channel blockers. Amiodarone is an antidysrhythmic that may convert atrial fibrillation, and it also slows conduction through the AV nodes, so it can help with rate control. If the patient's in a really rapid AFib and they are unstable, cardioversion or electrical therapy is used to reset the atria. And like I say, we'll talk more about this in class, so just a little bit of tidbits. Remember, too, that AFib is super easy to figure out. The rhythm is irregular, and there are no discernible T waves. Okay, folks, that's all of the recording to prep you for the EKG part of preclinical lab. We're going to continue with the other rhythms in lab, and I have placed some practice strips for you to figure out. Print them, figure them out, and bring them with you to preclinical lab. They are your ticket in. I'm expecting to see those for the EKG part of lab. If you have questions, you can email me at cummings@gatewayccu.edu and gatewaycc.edu if you have questions. Looking forward to seeing you all. Thanks so much.